Today I am presenting pneumothorax. Pneumothorax occurs when free air enters the potential space between the visceral and parietal pleura. Primary pneumothoraces occur without clinically apparent lung disease, either spontaneously or from penetration of the intrapleural space by trauma. Secondary pneumothoraces occur in patients with underlying lung disease. Causes of secondary pneumothorax include airway disease such as chronic obstructive pulmonary disease, asthma, cystic fibrosis, in which 8 to 20% will develop one in their lifetimes, interstitial lung disease such as sarcoidosis, pulmonary fibrosis, and tuberous sclerosis, infections such as human immunodeficiency virus infection and associated pneumocystis pneumonia, tuberculosis, necrotizing bacterial pneumonia, and lung abscesses. For connective tissue diseases, Marfan syndrome, Ehlers-Danlos syndrome, scleroderma, and rheumatoid arthritis. For cancer, generally primary lung or metastatic disease, and catamenial pneumothorax. The incidence of primary spontaneous pneumothorax is 10 to 18 cases for men and 2 to 5 cases for women per 100,000 population. Associated factors include cigarette smoking, male gender, mitral valve prolapse, Marfan syndrome, and changes in ambient pressure. Familial patterns also suggest an inherited association. Physical activity or exertion can precipitate but is not a common pneumothorax triggering factor. Traumatic pneumothoraces are subdivided into iatrogenic and non-iatrogenic. Chronic obstructive pulmonary disease remains the most common cause. Pneumothorax occurs in 5% of patients with acquired immunodeficiency syndrome, is associated with subpleural necrosis by pneumocystis infection, and carries a high mortality. Because of necrosis of lung tissue and continued air leak, simple aspiration fails in this group of patients. Hemopneumothorax occurs in 2 to 7% of patients with secondary pneumothorax, and, if associated with a large amount of blood in the pleural cavity, can be life-threatening. Treating the underlying disease may help decrease the risk of future pneumothorax. Under normal conditions, the parietal and visceral pleura are in closed apposition. The pleural space is negatively pressured at -5 mm mercury, with fluctuations of 6 to 8 mm mercury between inspiration and expiration. The inherent tendency of the chest wall is to expand and for the lungs to collapse from elastic recoil. With a loss of normal negative pressure in the pleural space that adheres the visceral pleura in the lungs to the parietal pleura in the ribs, the affected lung collapses. A primary spontaneous pneumothorax occurs when a subpleural bleb ruptures, disrupting pleural integrity. Rupture in primary spontaneous pneumothoraces usually involves the lung apex. In secondary spontaneous pneumothoraces, disruption of the visceral pleura occurs secondary to underlying pulmonary disease processes. Once there is a break in the visceral pleura, air travels down a pressure gradient into the intrapleural space until pressure equilibrium occurs with partial or total lung collapse. Altered ventilation perfusion relationships and decreased vital capacity contribute to dyspnea and hypoxemia. If air continues to enter the pleural space, intrapleural pressure becomes positive. Tension pneumothorax develops as inhaled air accumulates in the pleural space but cannot exit due to a check valve system. As intrathoracic pressure greater than 15 to 20 mm mercury increases, the great vessels and heart are compressed and shifted contralaterally, severely restricting venous return, diastolic filling, and cardiac output, causing ventilation perfusion mismatch and resulting in hypoxia and shock. Tension pneumothorax can develop in the presence of a chest tube if gas egress is obstructed, including from the adjacent lung. Classic symptoms of primary spontaneous pneumothorax are sudden onset of dyspnea and ipsilateral pleuritic chest pain. The pleuritic component of the pneumothorax may resolve within the first 24 hours. Profound dyspnea is rare unless the patient has poor reserve due to underlying parenchymal disease or develops a tension pneumothorax. Sinus tachycardia is the most common physical finding. Because many pneumothoraces are small, other classic findings like ipsilateral decreased breath sounds, hyperresonance to percussion, and decreased or absent tactile premitae are absent. In traumatic pneumothorax, the positive predictive value of ipsilateral decreased breath sounds is 86 to 97% for the diagnosis. Cough and exertional complaints are not common signs or symptoms. Except for trauma, physical exam alone is not sensitive enough to exclude a diagnosis. The clinical hallmarks of tension pneumothorax are tracheal deviation to the contralateral side, hyperresonance of the affected side, hypotension, and significant dyspnea. Pneumothorax is an important differential consideration in patients with chest pain, especially in those with underlying lung disease. Patients with pleurisy, pleural effusions, infiltrates, or shingles can present with pain similar to those with pneumothorax. A standard erect PA chest radiograph is the usual initial test and demonstrates loss of lung markings in the periphery and the pleural line that runs parallel to the chest. In spontaneous hemopneumothorax in particular, an upright chest radiograph may show large air fluid levels in the inferior portion of the right hemithorax, in addition to complete collapse of the entire lung. Ensure that the line does not extend outside of the chest cavity, suggesting a confluence of shadows or skin line. A lateral radiograph can identify a pneumothorax in an additional 14% of cases. An expiratory radiograph does not identify many additional pneumothoraces. The sensitivity of antero-posterior chest radiography compared to CT is lower, but with a specificity of 100%. In critically ill patients, when they cannot be moved to an erect position, look for the deep sulcus sign, a deep lateral costophrenic angle on the affected side. Large bullae in patients with chronic obstructive pulmonary disease may look like a pneumothorax, although a pneumothorax pleural line will run parallel with the chest wall, whereas bullae will have a medially concave appearance. Pneumothoraces usually cross more than one lung segment, whereas bullae are limited to a single lobe. A chest CT can differentiate the two. A thoracostomy with a chest tube inserted into a bulla mistaken for a pneumothorax results in a large pneumothorax, associated bronchopulmonary fistula, and its complications. Pleural adhesions cement the visceral and parietal pleura together, changing the appearance of the pneumothorax. Pneumothorax size may be calculated by the Light Index or Collins or Rhea methods, but most published formulae show only a modest correlation to actual pneumothorax size. The American College of Chest Physicians supports a method of measurement from the apex of the lung to the cupula of the thoracic cavity on an upright PA film. A measurement of less than 3 centimeters in this cephalad area is considered a small pneumothorax. Another method is to measure the interpleural distance at the level of the hilum. In this area, a distance of 2 centimeters correlates with pneumothorax of approximately 50% by volume. The British Thoracic Society defines a small pneumothorax as one with less than 2 centimeters rim between the lung edge and chest wall, and a large pneumothorax as one with a greater than or equal to 2 centimeter rim. Ultrasound detects traumatic pneumothorax with a reported sensitivity of 98.1% and specificity of 99.2%. The movement of the lung in what is known as the seashore, the lung is considered as the ocean, against the stationary chest wall, which is the shore, can be seen. In a normal lung, there is commonly a sonographic reverberation distal to the pleura that looks like a comet tail and a sliding sign of the movement of the visceral pleura along the parietal pleura. In the presence of interpleural air, pleural adhesions, effusions, and parenchymal disease, small pneumothoraces may be loculated, and therefore the sliding sign and the comet tail reverberation are lost, limiting the specificity for pneumothorax. Chest CT detects between 25 and 40% of pneumothoraces not visualized on a post-procedure chest radiograph. CT can detect other pathologies such as pulmonary blebs. If a chest radiograph does not demonstrate pneumothorax but there is clinical suspicion for the condition, such as in symptomatic high-risk patients, those with underlying lung disease or positive pressure ventilation, or after lung biopsy, obtain a chest CT. The treatment goal for pneumothorax is elimination of intrapleural air. Tension pneumothorax should be diagnosed clinically before a radiograph and immediately treated by needle decompression followed by tube thoracostomy. Treatment options are oxygen, observation, needle or catheter aspiration, single or sequential, and tube thoracostomy, either small-sized or standard chest tube. Oxygen administration at greater than 28% increases pleural air resorption to 3 to 4-fold over the base 1.25% reabsorbed per day, by creating a nitrogen gas pressure gradient between the alveolus and trapped air. Without supplemental oxygen, a 25% pneumothorax would take approximately 20 days to resolve. Recommended dosing ranges from 3 liters per minute nasal cannula to 10 liters per minute by mask and should be guided by the patient's status. We monitor for hypercapnia in patients with chronic obstructive pulmonary disease. Observation is appropriate for small, stable pneumothoraces only. If this option is selected, observe the patient for at least 4 hours on supplemental oxygen and then repeat the chest radiograph. If symptoms and chest radiograph improve, the patient should return in 24 hours for repeat examination. First-time spontaneous pneumothorax of less than 20% lung volume in a stable, healthy adult may be treated initially with oxygen therapy and observation. Aspiration or tube thoracostomy is selected based on likelihood of recurrence and likelihood of spontaneous resolution. Pneumothoraces in patients with underlying pulmonary disease are likely to recur. Large pneumothoraces and those with an air leak are unlikely to resolve without drainage. Inability to return for care or to tolerate any pneumothorax increase, such as in patients with poor cardiopulmonary reserve, should prompt drainage. When deciding to intervene procedurally on the pneumothorax, the stability of the patient, degree of symptoms, size and relative change in size over time, cause of pneumothorax, degree of underlying lung disease, likelihood of recurrence and resolution, and need for positive pressure ventilation are factors to consider. When patients are clinically stable, defined as respiratory rate less than 24 breaths per minute, no dyspnea at rest, speaks at full sentences, pulse greater than 60 and less than 120 beats per minute, normal blood pressure for a patient, room air oxygen saturation greater than 90%, and absence of hemothorax, various treatment approaches can be considered as follows. Single aspiration through the insertion of a needle or catheter, aspiration of air using an attached syringe, and immediate removal of the device. Needle aspiration through an 18-gauge needle provided in kits as an 8 French catheter over an 18-gauge needle. Small size catheters less than or equal to 14 French, small size chest tubes at 10 to 14 French, pigtail catheters at 14 French, placement using Seldinger technique, moderate size chest tubes at 16 to 22 French, and large size chest tubes at 24 to 36 French. 1 French is equal to 1/3 millimeters in diameter, and the larger the French number, the larger the device. The term catheter is used for any thin flexible tube. The selection of catheter or chest tube size is based on the flow rate of air that the device can accommodate. Large bore tubes are used for anticipated big leaks from mechanical ventilation. For tension pneumothorax, it can develop if a large air leak develops and small bore tubes and catheters cannot handle the airflow. Every chest tube has a proximal hole called the sentinel eye, which is visible radiographically and helps ensure that all drainage holes are inside the pleural cavity. When doing needle decompression, to decompress, use a 14-gauge needle for adults and an 18-gauge needle for children. Select a needle at least 5 centimeters long to penetrate the pleural cavity. 2 locations are recommended: into the second or third intercostal space just above the rib to avoid the intercostal artery at the midclavicular line, or in the fourth to fifth intercostal space just above the rib and at the anterior axillary line. If the needle is inserted medial to the midclavicular line, mediastinal vessels can be injured. A finger cut at its distal end can then be placed over the needle to fabricate a one-way valve. The Heimlich valve is still occasionally used for ambulatory treatment of pneumothorax, and serious complications with its use are rare. So treatment of pneumothorax, if it is a small primary pneumothorax, which is less than 20% or 3 centimeters apex to copula and asymptomatic, we observe the patients for 3 hours or more on oxygen, repeat chest x-ray, discharge of no symptoms, and return for check if symptoms recur or in 24 hours, or perform a small size catheter aspiration or a small size chest tube insertion, Heimlich valve, or water seal and admission, or a small size catheter aspiration with immediate catheter removal, then observation for more than 3 hours. For small secondary pneumothoraces, small size catheter or small size chest tube insertion with Heimlich valve or water seal and admission. For large pneumothoraxes, regardless of whether they are primary or secondary or bilateral pneumothoraces, moderate size chest tube and admission, large size chest tube if fluid or hemothorax is present, water seal and admission. For tension pneumothorax, immediate needle decompression followed by moderate or large size chest tube insertion, water seal drainage, and admission. Immediate chest tube placement is ideal. For needle or catheter aspiration, it is as effective as thoracostomy for treating the first episode of small primary or secondary spontaneous pneumothorax. Techniques include simple one-time aspiration with a large gauge needle or a small bore catheter, repeated aspirations through a small size catheter or chest tube attached to a one-way valve or water seal drainage. The catheter technique has the advantages of both aspiration and chest tube placement. The catheter technique for small-size catheters involves placing a small catheter either into the second anterior intercostal space mid-clavicular line or at the fourth or fifth intercostal space in the anterior axillary line after local anesthesia and sterile prep. Attach a three-way stopcock and use a 60 ml syringe to aspirate the pleural space until resistance is met, often triggering a pop. Close the stopcock, secure the tube, and obtain a follow-up chest radiograph to ensure lung expansion. Aspiration of more than 4 liters suggests continued air leak and failure of simple aspiration. Failure of the lung to fully expand warrants another aspiration attempt for formal tube thoracostomy and admission. When using pigtail catheters using the Seldinger technique, advantages include a smaller incision, less tissue dissection, and a smaller scar. You insert the needle into the pleural space, making sure placement is in the triangle of safety, which is bordered by the fifth intercostal space, the lateral border of the pectoralis major muscle, and the anterior border of the latissimus dorsi muscle. We aspirate fluid or air to verify location in the pleural space and advance a guide wire through the needle. Place a dilator over the guide wire until the pleural space is entered. Remove the dilator and place the chest tube over the wire into the pleural space. Remove the stylet, secure the tube, and attach the suction. For tube thoracostomy, it is used to treat a large pneumothorax, recurrent or bilateral pneumothorax, or coexistent hemothorax, or if there are abnormal vital signs or dyspnea. The chest tube is used in small spontaneous secondary pneumothoraces where large air leak is anticipated or noted. Standard chest tube thoracostomy with underwater seal drainage is the most commonly used approach, with a low complication rate and success rate of 95%. Most guidelines suggest using a small 10 to 14 French chest tube for non-trauma, conserving larger 14 to 22 French chest tubes if large air leak is probable, such as from mechanical ventilation or underlying pulmonary disease. There is no clear difference between simple aspiration and intercostal tube drainage in overall short and long-term outcomes. And simple aspiration is as safe and effective as tube thoracostomy for small volume air leak primary spontaneous pneumothorax. Complications of pneumothorax itself can include those due to hypoxia, hypercapnia, and hypotension. Re-expansion lung injury is uncommon and seen more often when there is collapse of the lung for greater than 72 hours, a large pneumothorax, rapid re-expansion, or negative pleural pressure suction of greater than 20 centimeters. Most patients need no treatment for re-expansion injury aside from observation or oxygen with virtually no adverse outcomes. Intervention complications include intercostal vessel hemorrhage, lung parenchymal injury, empyema, and tube malfunction, such as development of an air leak or tension pneumothorax. Pleurodesis for recurrence prevention is used in those with first spontaneous pneumothorax with a persistent air leak. Second ipsilateral spontaneous pneumothorax, first contralateral pneumothorax, bilateral spontaneous pneumothoraces, first episode of a secondary pneumothorax, or recurrent high-risk activities. Iatrogenic pneumothorax is a subset of traumatic pneumothorax and occurs more often than spontaneous pneumothorax. Transthoracic needle procedures such as needle biopsy and thoracynthesis account for approximately half of iatrogenic pneumothoraces, and subclavian vein catheterization accounts for one-fourth. Factors associating with the increased frequency of iatrogenic pneumothorax include patient population, underlying disease, body habitus, and experience of the operator. Ultrasound guidance for central venous catheter insertion for thoracynthesis reduces pneumothorax complication rate. Although it is routine to obtain a chest radiograph after central line placement or transthoracic needle procedures, it may not identify a pneumothorax if supine or if there is inadequate time for the pneumothorax to develop, with up to one-third detected later. Treatment for iatrogenic pneumothorax is generally the same as that for spontaneous pneumothorax. For small pneumothoraces, use a needle puncture, and those not requiring positive pressure ventilation can be observed or initially treated with small catheter aspiration with or without a Heimlich valve. Adequate for 60 to 80% of patients. Long-term recurrence is not a concern with iatrogenic pneumothorax. For air transport with pneumothorax, an increase in elevation causes an increase in the gas volume, which is boils low. So the same applies to diving, where development of the pneumothorax at depth may lead to tension pneumothorax by the SIP. So a high altitude flying is not recommended for at least 7 to 14 days after pneumothorax resolution, and current guidelines suggest that the history of spontaneous pneumothorax is a contraindication to underwater diving unless treated by surgical thoracotomy and normal lung function exists. So for the sake of consolidation, pneumothorax occurs when free air enters the potential space between the visceral and parietal pleura. Primary pneumothorax occurs without clinically apparent lung disease, and secondary pneumothorax occurs for patients with underlying lung disease. Under normal conditions, the parietal and visceral pleura are in close apposition, and the pleural space has a pressure of -5 millimeters mercury. With the loss of normal negative pressure in the pleural space that adheres the visceral to the parietal pleura, the affected lung collapses. Rupture in primary spontaneous pneumothorax usually involves the lung apex. In secondary spontaneous pneumothorax, disruption of the visceral pleura occurs secondary to underlying pulmonary disease processes. Tension pneumothorax develops as inhaled air accumulates in the pleural space but cannot exit due to a check valve system. Classic symptoms of primary spontaneous pneumothorax are sudden onset of dyspnea and ipsilateral pleuritic chest pain. For tension pneumothorax, you see brachial deviation in the contralateral side, hyperresonance of the affected side, hypotension, and significant dyspnea. We usually diagnose pneumothorax through chest X-ray, ultrasound, or chest CT. For treatment, options are oxygen observation, needle or catheter aspiration, and tube therapostomy. Patients with pneumothorax are considered stable if their respiratory rate is less than 24, no dyspnea at rest, pulse between 60 and 120 beats per minute, normal blood pressure for the patient, oxygen saturation of greater than 90, and absence of pneumothorax. And needle insertion is usually at the second or third intercostal space at the midclavicular line above the rib to avoid the intercostal vessels, or at the fourth or fifth intercostal space anterior axillary line. The triangle of safety for chest tube insertion is bordered by the fifth intercostal space, the pectoralis major, and latissimus dorsi. Complications of pneumothorax can include hypoxia, hypercapnia, and hypotension. For intervention complications, they include intercostal vessel hemorrhage, lung parenchymal injury, empyema, and tube malfunction. Iatrogenic pneumothorax is treated the same way as corresponding primary or secondary pneumothorax. And air transport and diving are contraindicated because an increase in gas volume increases with increase in elevation, which happens with both air transport